Thank you very much. That's there, right? Okay. So I'll take the next 20-ish minutes to talk about human factors engineering mainly. And the digitalization is following along in a way. So let me first start by stating if this would work. Now it works. By stating my conflicts of interest. First and foremost, I talk about what I do and what I love, so this kind of applies to me. But on a more serious note is, whenever I talk about products in this speech, I neither endorse nor bash them, right? Maybe I show some bad examples. That's how it is. Because I will talk a little bit about revenue streams for simulation centers, I want just to make it transparent that I added usability testing to our sim center, and we're using that to get revenue. And obviously I'm connected to SESAM, you heard about that. You see the logo down there, and you'll understand on the last slide where I will invite you to the next year's conference why I'm saying this. So let's start by asking ourselves a question, why? Why is it even important to think about human factors engineering, about usability in the context of today's healthcare? And I think this is a very important question, and you should start any work you do with this. Why are we doing this? For usability, it's pretty easy, because there are several reasons. First of all, everyone working in healthcare knows about the pressure building up within the system. And I don't mean this pressure, it's more like that one. The pressure to be more efficient, to do more with less, all these nice words, which in healthcare are a little bit difficult to implement. The other question why usability in the digital world is super important is because we are moving towards more and more telemedicine. Be it that we have restricted areas like a few years ago, be it that we have very remote areas where if you get sick here, it's super romantic, but don't have a heart attack here, right? So we need to transmit competence, medical competence, into very remote places. And this is where telemedicine plays a role. And telemedicine is digital. And the question is, how usable is that? And the third and most important reason why we do this, why we care about this, is the so-called work as done. When you see a presentation about, oh, this is a super new tool, like let's say this one, and then you try to use it, maybe sometimes it doesn't work as you expect. And work as done, this is an example from a German university hospital in the trauma bay in action. And you might ask yourself, what on earth are they doing? How can they end up doing this? Well, it's very easy, because you see, this anesthesia machine usually is parked here. But when the patient comes, the patient is back there, you have to push it forward. And then suddenly all these connections are standing in the way of the poor guy who needs to go back and forth with the lead on, with the stress, with everything. That's not good usability. That's a catastrophe, in fact. And a few weeks after we took this photo, someone fell and kind of hurt themselves. And you can't imagine how fast they put a thing hanging from the ceiling to connect the machine. Although years before, everyone flagged this. Or another photo which I took really last week. This is a, see, usability. It's not working again. This is a disabled toilet in Switzerland. And you might observe a slight problem here. I took a photo also from above. It's not one. So I tried to sit here, right? And just imagine you're in a wheelchair and try to... It has nice handles and everything. There is just no space. Someone designed this And probably they designed it this way because of this door. So yeah, it made sense, but this is not usability. And these are the problems we run into every day in every system, but in healthcare, they are really, really bad. And I'm trying to move forward. Now it's working. Because of the pressure I mentioned initially, we are trying to digitalize a lot of things. We are digitalizing the whole workplace, the patient records. We are digitalizing... I got a new one. Thank you.
Availability.
However, and this one I love, honestly. This is much more usable than the other because it has a laser pointer. Anyway, but it's not working. Yeah, no, it seems to be working now. It has a huge delay. Nah.
That's all we have.
That's all you have. Okay, then let me maybe say, if I say next one, oh, go back. This will be difficult if I can't control my presentation, but I'll try. Are you or am I? I will not press. Okay, you are not. Okay, it seems to work slowly.
Is it possible that the presentation is lagging?
No, I think it's more like the computer is very far and it needs to connect to talk to it. I'll try to stand here, okay? Anyway, so we are digitalizing a lot. Let me try to find my way back into my presentation. And the question is, if we are putting everything to become digital, have we solved the problem? Are we just jumping into a bright future? And I'm not super convinced of that. I think just because we use digital tools, we are not making things better. And sometimes we might even make things a bit worse. But let me now come to, my talk is also about safety. What comes to mind when you think about safety at the workplace? And I will show you a few drawings that you find on the internet if you say workplace safety. And it's usually about not tripping, wearing a hard hat, not getting your foot crushed, stuff like that. This is the common safety at the workplace. And this is important in the hospital as well. Remember that guy with the tripping risk? We tend to ignore these risks. This is important. But what I'm thinking about more is the safety culture. And the safety culture is a different thing from workplace safety. Because safety culture is a term that has been coined around this event, which those of my age might remember vividly. This is basically the catastrophe of Chernobyl, the explosion of the nuclear reactor there. And that's the event that triggered a lot of talk about workplace safety, and it has been coined by the International Atomic Energy Association, that thing with a lot of vowels that I cannot pronounce, IAEA, whatever. And they coined the term workplace safety, because safety culture, because it's the culture that makes a workplace safe or not safe. This reactor was, from a technical point of view, safe. But you could do unsafe things with it, and that's what happened because they didn't have the culture of making stuff work safely. They took a lot of risks at the workplace, and that's where safety culture comes into play. And that's where we need to pay a lot of attention also to the tools we are using. And now I'm coming to the human factors part of the equation. And human factors, if you read any publication about patient safety, you will find human factors here, human factor there. And I will briefly tell you a story. This guy is Max Planck. He has been a German physicist. He won the Nobel Prize in 1918, and he went to get the prize to Stockholm in 1919 because 18 was not a good time to travel for German physicists. And after he got his Nobel Prize, he toured all of Germany doing presentations about his results, and he has been driven by his chauffeur. Now, this is certainly Max Planck. This is most certainly not his chauffeur. It's just a picture showing a possible chauffeur. And what happened is he did the same lecture about his work in every university city. And this guy was sitting in the back row of the auditorium and listening to the same talk over and over again. And in the last city, let's say it was Munich, the evening before the talk, the chauffeur said, "Professor, I heard this talk so many times, I could give it myself." And Planck said, "Ah, really? Okay, let's do it." So they switched places. Planck put the chauffeur cap, sat in the back. The chauffeur gave a brilliant talk about nuclear physics because he learned it by heart. And in the end, someone asked a question. And the chauffeur said, "Sir, I am surprised that in such a renowned university city as Munich, you ask me a question so simple that even my chauffeur in the back can answer." So this is a nice story. I'm not sure it's true, but it shows a bit my position when I'm talking about human factors, because human factors is in fact a science. It's not something that a doctor can pick up by doing a 3-day course and then, we know about human factors. And this is what I want to stress, because human factors is widely used in the field of patient safety, but I assume it is very, very little understood what it is in fact. And to explain what it is and how we can use it to make systems safer, I will start by telling another story about aviation. So what you see here is an accident, obviously. A plane landed and skidded with no wheels, which is not good. Not good for the plane, not good, or like this, right? Same situation. And now you ask, and this has been around Second World War. Now you can ask yourself, how can it be that a good pilot flying a big plane in war conditions, coming home back in one piece, and then they do such a mistake after landing? And initially they blamed it on the pilots. Oh, they were tired. Oh, they don't know. They need more training, blah, blah, blah. This is the usual thing. We blame people. We say, you need more training. And then things will stop happening. Until someone looked at the cockpit of these planes. And you see, this is more or less generic, the cockpit. But here you have some switches. And the switches look super similar. This switch is putting the gear up and down, and this switch is putting the flaps up and down. So the flaps are used for landing, and after landing you want them raised again. And look at the switches, they are identical. They even have these guards, so if you just touch around, you will feel the same thing. And they are damn close to each other. So what happened is the pilots tried to raise the flaps and raised the gear after landing, so the plane fell down and had the accident. And this was the moment when people understood that design errors can cause accidents, and they changed the cockpit. This is a more modern cockpit design, and you will see the gear lever is here and looking like a gear, and the flap lever is here and is looking like a flap. And you can feel your way around. You touch the gear, you touch the flap, you know what you're doing, and they are spaced further apart. So basically, this was the birth moment of human factors engineering, which is a fancy way to say usability testing. And just think about medicine, how that might affect patient safety. And another aviation story is this accident, which has been an early prototype of the B-17 bomber, which took off and crashed. And no one understood why until they checked what has gone wrong, and they forgot to unlock a system. And then they coined the term, this is too much plane for one man to fly, by memory. And that was the birth moment of checklists. And now let's think back on healthcare. Look at this or at this, all of these machines here or this. And the question is if this design is conducive to a safe workplace, or this is maybe too much healthcare for one person to just handle like that. And this is where system design comes in. It's not the knowledge. You can be the most knowledgeable person, but you can still, if you mix two types of perfusion pumps, and this is an accident which happened, one perfusion pump has the display above the syringe and the next one has it below the syringe, so you change the rate on the wrong pump, knowing what you want to do, having all the correct knowledge, but doing the wrong thing. So the system design influences our workplace safety and the safety of our patients. And now we come to digitalization. We digitalize more or less everything, and these are different examples of user interfaces until telemedicine. And now the question is, do we know how safe this is to use? Or are we just using it because the hospital bought it and yeah, I have to use it anyway? And that's the crucial question. Because there is a fairly recent paper about the usability of electronic patient records. And I'll show you just some examples taken from the internet, which are kind of cluttered. This is not necessarily the best interface. And trying to move forward. And from hearsay, I heard that in some hospitals, maybe there even is a DOS-based system in use. I'm not looking at anyone. And mind, DOS-based interfaces are not necessarily bad. They are clearly structured. They might be better than something like this. You can work your way with a keyboard. Maybe they're better. I'm not sure. This should be tested. And this is scientific literature talking about how you can assess the usability of electronic patient records. And I'm convinced this has to be done because the results of this paper were not very good. And this is still an ongoing problem. This is a paper from, I think, 2 months ago. It's mid of 2025 about assessing the usability in healthcare generally and how to use human factors. And this is referencing a WHO publication, which is, I think, 150 pages just about making the system safer. And a big chunk of this is design of systems. It's not about make people more knowledgeable. That's important, but we do that. We train people. But are we looking at the design? I don't think so. And also they reference this paper, which talks a lot about ergonomics and human factors in the design of systems. And now I'm circling back to the fact that we are at the 5th anniversary of a simulation center. And simulation centers traditionally are used to train people. And remember the first pilots, the idea was, let's train them more. And training is very, very important. If you put a non-knowledgeable person in that plane, regardless how good the plane is designed, they will crash it. So training is important. Training is not everything. And that is probably my main message here. I can share these papers if you'd like. Because I think we should, as people who are rooted in education and simulation, we should expand our thinking. We should go, there is a very good framework about systems thinking, which I just very briefly show here. A system consists of more than people. A system consists of rules, things we use, machines, equipment, and all of those interact. And we in education and simulation need to look at the system. And we also should talk to our procurements, to our administrations. Because Usually people look at this, how useful is it? They look at how affordable it is, but how often do they really check if something is usable for the people? How often do they ask you, the healthcare professionals, before buying a system, look, like we have 3 systems here, try them out, which one is the best for your work? I would bet close to never. And this goes for equipment, and this goes for spaces as well. Remember the guy tripping over the cables? That was a design not thinking about the work as it's being done every day. So these are the points where we can influence the system in more than just educating people. And we need, and these are pictures from my sim center, we need to test. We need to really, really test. This was a test on a OR video management system that has been installed in the center by the company producing it. And we had real OR nurses and surgeons use it in a simulated scenario again and again and again. And you see, they've been filmed what they have been doing. And in the end, there has been a lot of discussion about what went well and what didn't go well, but not focused on the people, but focused on, okay, you didn't find that thing for, let's say, 10 seconds. Why? Because it was hidden. It was unclear where it is. And then they got a report with marks for every aspect of this system, and highlighting on the interface what needs to be changed and what not. And this is work that can be done in a simulation center. And we used it to, let's say, expand our revenue sources. Simulation centers are clinical spaces that have no patients in them, but you can easily test this, and this is a huge contribution, I believe, to patient safety as a whole. And we need to enlarge our teams. I said, I'm the chauffeur here. We need the Max Plancks in our teams. We need human factors engineers in our teams. We do have one in Munich. You can study human factors engineering, and suddenly these people come and tell you a lot of things where you're like, interesting. And you can implement that. So we need these people in our teams, and we need, all along, to adapt the curricula also for all healthcare professionals to include this system thinking. Because otherwise they will be very well trained and very frustrated by non-usable stuff they have to put up with. And that's not a system safety thinking. And more importantly, we need, like I'm doing right now, to spread the word. This is important. This is not just something like, I can use this, I can use that, who cares? Yeah, standing here giving a presentation, who cares? Having an ICU patient where maybe I changed the rate of the wrong medication, that's not who cares. And this is where the system comes in. And with this, I come to a conclusion. It's important that we all work on this together, because otherwise things will not advance. And I conclude by, of course, inviting you next year to Lyon in June to the Sesam conference. That's why I have the Sesam logo all the time, so I can do this safely. Thank you very much for your attention, and open to conversations.